Thank you for the opportunity to be here to talk to you about multiple myeloma, and thanks for the nice introduction. I'm going to talk about the new consensus guidelines for diagnosis and response in multiple myeloma. I'm going to go over an overview first, and then we're going to go over the new guidelines for diagnosis, response, and then I'll take any questions. As you know, multiple myeloma is a hematologic malignancy that affects the bone marrow of patients and also the bones. And it is associated with multiple morbidity and mortality. There are about 100,000 new cases worldwide and about 72,000 deaths. The cases of myeloma are also expected to increase significantly in the next few years, mainly due to an aging population and possibly also to better diagnosis tools. The incidence rate of multiple myeloma in Asia is around 0.5 to 3 for every 100,000 people, and the average age of diagnosis is around 62 years of age. In North America, the incidence is higher. It's about 6.3 of every 100,000 people. It is higher also in African Americans, and the age of diagnosis is a little bit longer, usually around 69, 70 years of age. This plasma cell malignancy is marked by molecular heterogeneity. As you all know, not all myeloma is created equal. And there is a natural history of progression from MGUS and smoldering myeloma, which creates a unique opportunity to study this disease. Currently, the definition for myeloma requiring treatment requires that the patient has evidence of end organ damage or biomarkers of malignancy. And you have the biomarkers of malignancy listed here, and we'll go over them in a little bit more detail in the next few slides. You also have some subgroups through gene expression that detail the heterogeneity of myeloma. I also wanted to point out that we do have a new revised international staging system that is based on more than 4,000 patients from 11 international clinical trials. This was truly an international effort to do a new staging system for myeloma. This is based on 3,000 young and elderly patients that had data also for the international staging system, which is the older staging system that we used until a few years ago. LDH and cytogenetic abnormalities. And these patients were treated with modern era medications, with immunomodulatory drugs and proteasome inhibitors, and the median follow-up was 46 months. And what you can see here is that the staging is based on the albumin, the beta-2 microglobulin, cytogenetics abnormalities, including FISH, and also LDH. And if you don't have any high-risk cytogenetic abnormalities, you have a serum albumin of more or equal than 3.5 and a beta-2 microglobulin of less than 3.5 with a normal serum LDH, then you're low risk. And if you have a beta-2 microglobulin of more than 5.5, any high-risk cytogenetics, which are defined as deletion 17p, translocation 414, or translocation 1416, or a high serum LDH, then you're ISS stage 3. And if you have anything in between, then you're stage 2. And you can see the overall survival for 5 years in stage 1 is 82% compared to 40% in stage 3. So this staging gives you an opportunity to identify those patients that do not have good prognosis and maybe to do some difference in the treatment so that they can have better outcomes. So it is an important staging system to all your patients using in the clinic to stage them according to this. So we'll talk about the new guidelines for diagnosis. So this is a little schema here. Let me see if you can see. Okay. So this is the tumor burden from less to more. We've talked about MGUS and smoldering myeloma being natural precursors of multiple myeloma that needs treatment. And so the definitions have been in the past a little bit arbitrary based on studies of progression. So a long time ago, I think Dr. Kyle figured out that if patients had less than 3 grams per deciliter in the blood of M protein, less than 10% plasma cells, and no end organ damage, the risk of progression was significantly different than those patients that had an M protein that was more than 3 grams, that had more than 500 milligrams of protein in the urine. These are the monoclonal proteins, more than 10% plasma cells. And based on this was crudely differentiated into MGUS and smoldering. With time, we've figured out that this smoldering myeloma is actually also very heterogeneous, with subpopulations of patients that have lower risk to progression, very similar to MGUS, and some patients that are very similar to myeloma. And so the new definition for diagnosis takes into account these patients with smoldering myeloma that are close to this line here, where they would have myeloma requiring treatment, but they have not yet developed end organ damage. So for the diagnosis after the guidelines published in 2014, the main difference is that there have been some biomarkers that have been identified through different studies, mostly retrospective studies, showing that these patients that have, for example, more than 60% plasma cells in the marrow, that have an involved-uninvolved free light chain ratio of more or equal than 100, or more than one lesion on MRI that can be identified as myeloma, these patients have a risk of progression that is around 70–80% at 2 years. And through a consensus guidelines, it was decided that these patients should now be treated as myeloma. So any patients that have these biomarkers here should be myeloma. And on the contrary, patients with smoldering myeloma up to, I guess, 59%, although you can see this is also a little bit arbitrary, right? 59 is almost the same as 60, but you have to put the cutoff somewhere. So 10 to 59% plasma cells is still smoldering, okay? And you have the criteria here. I don't know if you have the slides, but, and basically these are the main changes. And this is just one slide reminding us of this definition of MGUS and smoldering. For smoldering myeloma, the average for transformation to myeloma is about, for 5 years, is about 50%. Again, there are some patients that do not progress here. Most of them do, but some of them do not. This is a very long-term follow-up, 25 years. So sometimes it's difficult to predict the individual risk. This is one of these publications that talked about having more or equal than 60% bone marrow plasma cells. So this was a publication from a retrospective study from the Mayo Clinic a few years ago that was published as a letter. And what the authors from the Mayo Clinic saw is that when they looked back to about 650 patients with smoldering myeloma, and they looked at specifically this biomarker of the percentage of plasma cells in the bone marrow, the ones that had less than 60% plasma cells progressed at a much lower rate than the ones that had more or equal than 60%. What you can see here is most patients that do have, 60% plasma cells in the marrow, most of the times they already have CRAB criteria. They already have the kidney dysfunction, or usually they have anemia. So it's a very small percentage of patients that have this degree of burden in the bone marrow and actually have not yet developed any symptoms from this. It's a very small proportion. It's 2–3% of all the patients. And this is what you see here. And I believe there have been other studies published also later on after this was published, saying a similar thing, that it's also a small percentage of patients that they do progress quicker. The next one is the involved divided by the uninvolved free light chain ratio. So this is if you have a IgG kappa myeloma. This is the kappa by the lambda. If you have an IgG lambda, it's the lambda divided by the kappa. And it has to be equal or more than 100. What you see here is for those patients that had this biomarker that was more than 100, the time to progression, in this case, was around 70% at 2 years. And then this is the study showing that if you had more than one lesions on whole body MRI, that also this portended a significantly increased risk of progressing to myeloma in the following 24 months. And basically all of these three biomarkers, what they show is that the risk of myeloma is too high so that we would just establish treatment beforehand. So this is why the diagnosis for myeloma changed. So in summary, before 2014, what we used for myeloma that required treatment was the CRAB criteria, and after 2014, we're using still the CRAB criteria, but also biomarkers of malignancy. We're also going to go over the new guidelines for response very briefly. Why do we need new definition for response assessment for myeloma? Well, this is due to the fact that we have deeper responses with the novel medications, and we also have the need to assess for minimal residual disease. Using all the therapies, even with an autologous stem cell transplant, patients did not achieve complete remissions in most occasions. It was definitely less than 50%. But now using the novel therapies up front, using consolidation and maintenance, definitely more than 50% of patients achieve a complete remission. However, even those patients that have a complete remission, they still relapse, and this suggests that there is persistent disease that we cannot detect with the current recommended guidelines. And so these new guidelines were made so that we can go a little bit deeper, assessing minimal residual disease. In this response assessment, there really has been no change in the definitions of progressive disease, stable disease, minimal response, partial response, very good partial response, complete response, and stringent complete response. The only thing perhaps in progressive disease or relapse is that now there's a category that if you're minimal residual disease negative, then you can turn into minimal residual disease positive, and that would be considered relapse, but it is not a clinical relapse. So there is no recommendation to treat if you go from MRD CR, MRD negative to CR, MRD positive. There has been a big change in minimal residual disease criteria, which is the first time that we have this in myeloma. And there are basically 4 categories: a sustained MRD negative, flow MRD negative, sequencing MRD negative, and imaging plus MRD negative. These are basically the standard criteria that have been published very recently. And here you can see that this is very similar to what we've been using in the clinic, at least in our clinic at MD Anderson. And you can read this, but basically if you have a complete response, you have negative immunofixation and urine disappearance and any soft tissues plasmacytomas, and less than 5% plasma cells in the bone marrow. What we call a stringent complete response requires all of these things in the complete response, but then also that the plasma cells in the bone marrow cannot be clonal. And then you also need a normal ratio in the serum free light chains. For the minimal residual disease criteria, I'm just going to go over here a little bit. So sustained MRD is when you measure minimal residual disease in the bone marrow by next generation flow or next generation sequencing or both, and also by imaging, with this definition where there is a disappearance of every area of increased tracer uptake found at baseline or a preceding PET-CT. And then and this has to be for a minimum of 1 year. And then the subsequent evaluations, you can say 1 year MRD negative, 2 years MRD negative, 3 years, and so on. By flow, they have put this definition where there cannot be any aberrant clonal plasma cells. As you know, by flow cytometry, you can detect in a very sensitive way, especially with next generation flow, the number of aberrant versus normal plasma cells in the bone marrow, and this can be reported in the regular pathology report. Here, they want us to use the Euroflow standard operation procedure or similar or equivalent method. So there are currently 2 methods. One is the Euroflow, which uses 2 tubes, 8-color flow cytometry. And then there's another one that we're also using, which is a 10-color flow cytometry, 1 tube. And they both have a sensitivity of around to basically found 1 in 10 to 5 cells that could be myeloma. For sequencing MRD negative, you need to have absence of clonal plasma cells by next-generation sequencing on the bone marrow aspirate. The presence of a clone is defined here as less than 2 identical sequencing reads obtained after DNA sequencing of bone marrow aspirates, using lymphocyte platform or an equivalent method. And the minimum sensitivity is also 1 in 10 to 5 cells. So currently, we're not using sequencing at MD Anderson for minimal residual disease detection. However, there have been many studies showing that the sensitivity of sequencing is better than flow cytometry. So we are actually working now to get sequencing at MD Anderson, and currently what we do is minimal residual disease flow. So far, it is not changing what we do if the patient is MRD positive or negative. For example, if a patient finishes transplant and consolidation treatment and then their CR MRD positive or MRD negative, we still give them maintenance to both of them. So I think that in the future, I'm not sure if this is going to change, and there are many ongoing studies now evaluating what is the role of minimal residual disease in the treatment, to see if treatment needs to be stopped early if you're a minimal residual disease negative, if you need more treatment if you're positive, and so on. For imaging, we do use a lot PET-CTs, especially to detect. Sometimes there is hidden disease. If a patient is going to transplant and they have had prior extramedullary disease, we usually check a PET-CT to make sure that there's nothing left before they go to transplant. In this case, for the criteria, you need to have disappearance of tracer uptake for myeloma for a patient to call them incomplete remission, basically. And for that, you either have to do a PET-CT at diagnosis or at relapse, when they relapse, and then if they have any areas of uptake in the bone marrow, or if they have lesions somewhere else, or extramedullary disease, those have to go away. And it's actually the PET-CT, I do think it's very useful for myeloma. There are actually several studies, I believe at ASH also, there was a publication talking about the usefulness of PET-CT in myeloma. And it's something that we use quite a lot. Okay, any questions about this? No.
New England Journal of Medicine's. Everyone, please give a warm welcome to Professor Alaskis.
Thanks very much. I'm going to tell you a little bit about how to think about treating your newly diagnosed patient who could be eligible for stem cell transplant based on some of the available regimens, mostly with a focus on some of the drugs available in the US, but as I mentioned earlier, many of these are now becoming available more generally. These are actually the updated NCCN guidelines for transplant-eligible patients with myeloma. And the interesting thing is that even though we have more drugs now available, the number of options has actually decreased a little bit, if you remember from the past, because you'll see that the preferred regimens now are just 3: Bortezomib with cyclophosphamide and dexamethasone, or Bortezomib with doxorubicin and dex, or Bortezomib with lenalidomide and dex. And some of the category 1 recommendations have actually been moved down to less preferred or other regimens, including things like Bortezomib with thalidomide and dexamethasone, and the 2-drug combos, Bortez and dex and len and dex. So I thought I would just go through some of the data that really support the various recommendations. There have been lots of studies looking at CyBor-D in myeloma, and I didn't want to go through all of them, but this is just one which showed that it has a very good response rate, usually 75 to 90% of patients. And it does have the advantage that in most places cyclophosphamide is relatively cheap and therefore easier to give than perhaps more expensive drugs like lenalidomide and thalidomide. The interesting thing about it still being preferred is that there was an abstract not at 2016 but at 2015 ASH where the French compared CyBor-D to Bortezomib, thalidomide, and dexamethasone. And what they found is that after 4 cycles, this is not until progression, after just 4 cycles, that the Bortezomib, thalidomide, and dexamethasone had a better overall response rate and also a better VGPR rate or better. And so in some ways, if you're only going to do 4 cycles of therapy, it may be that CyBor-D is not your best choice. And the adverse events were what you would expect, a little bit more cytopenias with the cyclophosphamide, but more GI and neuropathy events with thalidomide. One of the options as category 1 and preferred is bortezomib with doxorubicin and dex, and I'm sure you remember the Dutch and German trial which showed that if you gave bortezomib with doxorubicin and dex, then transplant, and then bortezomib maintenance, you had a better overall outcome, especially if you had a deletion of 17p, which a little bit answers some of the questions that Dr. Lin asked earlier about that subgroup. The most recent data, this paper was actually just published within the past few weeks, which was the SWOG study that compared lenalidomide and dex versus bortezomib, lenalidomide, and dex, both given for 8 cycles. And then on both arms, patients went on to get lenalidomide and dex as a maintenance. And you probably know the data showing that VRD had a better progression-free survival. And this was both in transplant eligible as well as transplant ineligible patients. And interestingly, the survival data were better as well, which is a little bit surprising considering that they only got maximally 8 cycles of a bortezomib-containing therapy before going on to len and dex. And if you look at the response rate and quality, you'll see that the overall response rate was better if you got the 8 cycles of bortezomib-containing therapy, and there was also a trend towards a better, very good partial remission. Other combos that are up there, bortezomib and dex, this is just one of the studies that compared, for example, VD to the old standard VAD and found that it was at least as good, if not better. And then bortezomib, thalidomide, and dexamethasone, which again has been studied by many groups, including the Italians, who showed a better event-free and progression-free survival, which was maintained after transplant, which tells you that the better your upfront therapy is before transplant, the better will be the outcome after transplant. Lenalidomide and dex was down there as one of the other regimens, and again, a number of studies, but this one from ECOG was very instructive because it compared len with high-dose dex to len with low-dose dex and showed that the low-dose dex regimen was at least as good and maybe a little bit better in terms of survival. And that was exciting because usually in oncology, we think that if a little bit is good, more has to be better. And in fact, here the opposite was true. You could do just as well or better with less therapy, in this case with less dexamethasone. One new combination that made it onto the list is actually Ixazomib with lenalidomide and dexamethasone. This is interesting because although you know that IRD is approved in the relapsed setting in the US, it hasn't yet been approved for newly diagnosed patients. But because of this phase 1/2 study with an all-oral regimen, which showed that there was a good overall response rate, and you can see that about 27% of patients had a complete remission after 12 cycles with a very well-tolerated oral regimen. This was in part what led to that being listed as an option. And you can see from this waterfall plot that quite a few patients had a 100% reduction, and many more had a 90% or more and a 50% or more induction benefit. And of course, although Ixazomib is a new drug and will probably be a little bit expensive to start with, the flip side is that because it's oral, it could ultimately be cheaper because you don't have to administer the drug intravenously or subcutaneously. You don't have to get the pharmacy involved. You don't have to get the nurses involved. You don't have to bring the patient to your clinic. And so ultimately, from a cost-benefit perspective, this may be something to look at. Now, Carfilzomib with len and dexamethasone was included in that, and this is based initially on Andrzej Jakubowiak's work, where they were able to show that there was quite a nice, almost 100% response rate with this combination, and a high rate of stringent complete remission, suggesting that maybe KRD could be better than VRD. And this is being tested now in the US by a cooperative group study, which is comparing VRD to KRD head to head. And I think that probably KRD will be better, although you may remember that there was a press release from the study in transplant ineligible patients, which compared Bortezomib, melphalan, and prednisone to Carfilzomib, melphalan, and prednisone. And in that study, there wasn't a difference in outcomes. So we can't assume that we know what the results will be. Additional data about KRD were presented at this past year's ASH meeting from the French group. They did KRD as an induction, then they did transplant, and then they did KRD as a consolidation. And they found overall, you can see 57% of patients had a stringent complete response, and a large proportion of patients were also MRD negative, both by flow as well as by next generation sequencing, which again suggests that maybe KRD will be very attractive. And the more therapy that you got, as you can imagine, the better was the quality of the response. The main issues were that there were some cardiac events, and this is something that is a pattern with Carfilzomib. The rates are low, but they are there, and this is something which we're studying in more detail to try to understand whether some patients have a higher risk than others. And cardiac and pulmonary toxicity is broken out here. You can see that there were a small number of events of cardiac failure, pulmonary embolism, and cardiac arrhythmias, which is certainly something to watch for. One of the interesting things from the SWOG study I mentioned earlier, and you could probably show these curves from any trial, is that the quality of the response led to a better outcome. Meaning if you had a VGPR or greater, you had a better progression-free and overall survival than if you had a PR or than if you had stable disease. And so that raises the question of whether some kind of response-adapted therapy may be the best way to go. And there was one study presented at ASH, which was the MRC11 trial, that was kind of interesting. What they did is, you can see they randomized patients to get either cyclophosphamide, thalidomide, and dex, or cyclophosphamide with lenalidomide and dex. If patients got a VGPR or CR, they went on to transplant. But if they got a PR or MR, or stable or progressive disease, they could get randomized to either no further therapy or to addition of bortezomib with cyclophosphamide and dexamethasone. If you look at the here column that says after CVD induction, you can see that those patients who got Cybor-D after the IMiD regimen had almost a 40% improvement in the quality of their response, and this was maintained after stem cell transplant. And when you look at the long-term outcomes, you can see that progression-free survival was much better if you got the Cybor-D than if you did not, although overall survival was not yet different. But that's not unusual in these transplant-related studies where it can take a little bit more time to go ahead and see a difference. But you can see in the subgroup analysis that if you got Cybor-D added, virtually every group of patients did better, suggesting that maybe what you need to plan on is 4 cycles of induction. If you have a great response, keep going to transplant. But if your response is sort of then maybe you need to add a different combination with additional novel drugs. And here again are the transplant eligible data that show good outcomes. And as you can imagine, the toxicity of adding the Cybor-D was mostly in the thrombocytopenia and neutropenia category. Now, I also was asked to look at 2, 3, or 4 drugs, and right now there aren't that many studies really that looked at 4 drugs as induction. One of them was this evolution study from Shaji Kumar, which was a relatively small study, so I think it's tough to make too many conclusions, but they randomized patients to get either Bortezomib Len and Dex, Cybor-D, at 2 different doses of cyclophosphamide, or the 4-drug combo of Bortezomib, Len, cyclophosphamide, and dexamethasone. These are the progression-free survival data, and actually it looked like the Bortezomib, Len, and Dex, which is the top curve, did a little bit better, although this was not statistically significant. And these were the overall survival data. But in both of these, the 4-drug combination did not do better. Whereas, again, if you look at the response rates here, the VDCR in the middle had a trend towards maybe no difference in response rate, and yet the toxicity was greater. So you're not really benefiting there. And then this study, although it wasn't for transplant-eligible patients, but it's one of the few other trials that looks at 4 drugs versus 3 drugs, even there it wasn't straight up, because this was Antonio Palumbo's study where he did VMP versus VMPT, and the VMPT patients got VT afterwards, whereas the VMP people did not. And if you look at 54 weeks of induction, you do see a small difference in outcome. But if you're thinking about 4 cycles of induction therapy, it doesn't look like 4 cycles of 4 drugs is going to be better than 4 cycles of 3 drugs. Other options, Jayton Shaw from our center has done a study with RVD and panabinostat, which showed a nice overall response rate. And after only 4 cycles, half of patients were MRD negative. So we're going to hopefully publish these data soon. And then through SWOG, we did a study for high-risk patients where we did RVD versus RVD plus elotuzumab. So far, the only thing we've been able to publish are toxicity data, but hopefully at this year's ASH, we'll be able to show some of the efficacy data. So I think the conclusions that I would leave you with are 2 drug combinations can be used in some cases. I think if you have an older patient or a patient with lots of comorbidity, or if cost is an issue or drug access, I think it's fine to do something like Lendex or Bortezomib Dex. But in general, 3 drug regimens are the current standard of care, and that could be a PI with an IMiD and a steroid, or a PI with an anthracycline or alkylating agent as a steroid. And adding a 4th drug right now, we really don't have enough data to really support doing that. I think the future challenges are we're going to start seeing data with an antibody, an IMiD, and a steroid induction, and it'll be interesting to see whether those are better, the same, or worse than a proteasome inhibitor, IMiD, and a steroid. And especially, I mentioned earlier that an oral proteasome inhibitor could be cheaper, so maybe that would win out. The other problem with 4 drug regimens is the cost. Given that the added cost is going to be much greater, I think the benefit will have to be substantially greater, not just like a 20% improvement. I think we really need a huge improvement to justify giving 4 drugs, although antibodies seem to be the best option because they add relatively less toxicity than, for example, an alkylating agent. And then the other question is, if we do 4 drugs, should we give 4 drugs up front? Or should we do, as I showed you, a treatment or risk-adapted approach? For example, maybe high-risk patients should get 4 drugs and standard risk patients should get 3 drugs. Or maybe you should do 3 drugs for 4 cycles, and if you don't have a good response, then you add the 4th drug. And these are things that hopefully we can all work together to try to answer, because although patients are doing a lot better, there are still many folks dying from myeloma, and hopefully we can do better than that. So thanks very much, and hopefully we have a couple of moments to answer questions.
The Hematology Consortium as well. Please, Professor Palmer.
Thank you. Thank you for a great introduction. So today I will be talking about stem cell transplant strategies for multiple myeloma. And actually I've divided the talk into 3 parts. The first part is actually just defining stem cell transplant. Second part is post-transplant maintenance, and third part is post-transplant consolidation. And in interest of time, I may skip a couple of slides, but they're all here for your access. So in general, whenever we are approaching a multiple myeloma newly diagnosed patient, we are upfront determining whether they are transplant eligible or not, and based upon their eligibility, the transplant eligible patients, they are put into the cohort of induction followed by consolidation with the autologous stem cell transplant, and then evaluation for post-transplant strategies. And eventually they may or may not relapse, but we're always ready for that thing to occur. In general, multiple myeloma constitutes the majority of the autologous stem cell transplants that are performed, at least based upon the CIBMTR registry. And the survival, the overall survival of patients with myeloma undergoing transplant is actually improving over the last several years. So the question comes, why do we even transplant our patients? And this actually is based upon data that stems from the late 1990s in terms of randomized clinical trials where half of the patients were randomized to undergo autologous transplants and the other half got conventional chemotherapy. And at least 2 independent studies showed that they had not only improvement in progression-free survival, but also statistically improvement in overall survival. And then these studies were repeated in other areas as well, but definitely almost all of them showed improvement in progression-free survival. And fast forward now with the novel agents, this is the data from Dr. Palumbo and was published in New England Journal, where they had looked at upfront patients with MPR, which is melphalan, prednisone, Revlimid, versus MEL200, and patients who got transplanted did better in terms of both survival and progression-free survival. So this is the data that was published recently, IFM 2009, in which patients got RVD plus minus autologous stem cell transplant, and all of them got lenalidomide maintenance. And what you can see is that definitely after RVD, they had good responses with a CR rate of almost 50%. And after transplantation, actually, they also had similar responses, but when you look overall, the CR rate went from 49 to 59%. So definitely the depth of response increased, and even the MRD went from 65% to 80%, which was statistically significant. But most importantly, the 4-year progression-free survival was statistically significant in favor of patients undergoing autologous stem cell transplant. This was the data that was presented at ASH meeting, and basically all of these patients had VCT induction followed by randomization of either undergoing autologous stem cell transplant, single or double, based upon the actual center, and the other half got continued additional cycles, and they had a second randomization going through VRD consolidation and no consolidation, and finally lenalidomide maintenance. The bottom line here was that patients who got autologous stem cell transplant, and you can see this was a large number of patients, they had better progression-free survival, whether they had standard risk cytogenetics, they had improvement in the progression-free survival in favor of autologous stem cell transplant. You can see almost 77% versus 70%, and in high-risk cytogenetics, which was 55% versus 43%, and it also correlated with the depth of response. So the conclusions, at least based upon this study, was that the upfront autologous stem cell transplant significantly prolonged progression-free survival versus VMP in patients with newly diagnosed myeloma, and also increased the depth of response. So the question comes, what about minimal residual disease? Should we actually worry about it? And the answer is yes. So even after autologous stem cell transplant, if the patients are in morphological CR, MRD is actually gaining more and more strength, and this is reflected by these graphs in which you can see that the time to progression in the patient patients who were MRD negative was definitely significantly longer compared to the patients who were MRD positive, and it translated into overall survival benefit as well. And there was a recent question that was asked in terms of the value of PET scan and MRD negative, and overall, at least more and more data is coming in favor that the more stringent CR we have, the more negativity we have, both in terms of MRD as well as the imaging studies, it is translating into better progression-free survival, at least based upon this data. Then the question is about age. What about age for eligibility for transplant? And again, as mentioned by Dr. Arlowski, that age alone by itself should not be considered as a factor for ineligibility. And this is actually data from CIBMTR, which shows the inherent bias that we have even in the presence of all this new data, that patients who are older, especially they are 65 years of age, you see the white bar is basically the incidence of newly diagnosed myeloma, but proportionally a very small fraction actually moves forward with transplant, and you can see that this kind of proportionality is much lesser in younger patients. This is the data that was presented and basically showed that patients who are more than 60 years of age or equal to 60 years of age compared to the younger patients, there was no really difference in terms of overall survival when they undergo autologous stem cell transplant. And in terms of the patients older than 66 years of age, and this is from the Medicare data, the SEER Medicare data, both 3 and 5-year-old survival is actually improved in the patients undergoing autologous stem cell transplant in the older population as well. This is the data presented by Dr. Shaji Kumar, in which they had looked at a clear watershed between patients younger than 65 years of age versus more than 70 years of age. And clearly you will see that there was really no difference in terms of mortality, no difference in terms of infections. The only difference was in terms of the duration of hospitalization, but overall outcomes were not different. And this is data from our own hospital at MD Anderson by Dr. Bashir, who had specifically looked at patients older than 70 years of age, and you can see that the 5-year overall survival was close to 70%. So the take-home message is that age alone should not be a category for making a patient ineligible, but it's actually their physiological age, their performance status, and many times you will see that the patients may not look eligible upfront, and after treatment they may gain their functionality. So in the back of your mind, you should always at least think about or at least discuss with your patients about autologous transplant. So the next question comes, what about renal disease? Because a lot of patients with multiple myeloma may present with chronic renal insufficiency, or they may be on dialysis as it is. So in general, at least it's our understanding and based upon the data is that renal disease by itself is not a contraindication for autologous stem cell transplant, and they should definitely be offered this modality. And we do not do dose reduction based upon renal insufficiency. The only time we do dose reduction is based upon performance status or age. So the next question comes, should we maximize a response prior to autologous stem cell transplant? And this was presented by Dr. Ravi Vej from St. Louis, in which patients after diagnosis and initial induction, or the patients who had less than a partial response, they were randomized either to undergo salvage chemotherapy or straight away go to autologous transplant with no salvage therapy. And basically what at least he showed was, and you can see that at the bottom, there's almost 10-year survival, that there was really no difference in terms of salvage versus no salvage therapy prior to autologous stem cell transplant. But because this may be in the era of not having the novel therapeutics, it has to be taken with some pinch of salt. At this time, we try to maximize the responses prior to transplant, but we don't really delay too much in the fear of either creating stem cell toxicity or making the patient debilitated or having too much side effects. There are certain instances when we do harvest and hold, but those are exceptional and based upon patient discussion and how they feel about proceeding. So the next thing comes, what about timing of autologous transplant? In general, the sooner the better. This was a study in which they had compared early versus late autologous stem cell transplant. And really, in terms of overall survival or progression-free survival, there was not much difference. The only major difference was that the patients who got early autologous transplant had lesser chemotherapy exposure. So again, at this time, we try our best to take the patients sooner to autologous transplant, but you're not going to harm your patient in terms of if there is delays or if you want to look for other therapies or if there are delays because of side effects and such. So stem cell mobilization, in the era of novel agents, there is always concerns about the stem cell toxicity, and there may be delays in the mobilization or some retardation. In general, we rely on traditional methodologies of using GCSF as a starting criteria. There are data in terms of plerixafor for mobilization, and this was a randomized study looking at GCSF plus placebo versus GCSF plus plerixafor. And basically, you can see is that the collection of the stem cells was definitely at a shorter period of time, and they had higher dose of infused cells. But in terms of clinical outcomes of either overall engraftment or actually moving to transplant was not statistically significant. So at this time, even if patients are exposed to prior novel agents, we try to start with GCSF, but if they have some underlying disease or if they still have some less than a PR, then we may give them some chemomobilization. In patients who've gotten extensive exposure to Revlimid in the past, we have a low threshold of starting of plerixafor and or putting them on chemomobilization. So next comes the second part of the talk, which is post-transplant maintenance. And as we are moving forward in this field, we feel that autologous transplant is just one of the many players in the treatment paradigm for the patient. And it is very important that we look at the chronicity of multiple myeloma, and we continue to tackle with the myeloma clone by offering them options like maintenance and consolidation. So there are three major agents, at least right now, evaluated for and have good data in terms of post-transplant maintenance. And I'll talk about thalidomide, bortezomib, and lenalidomide. And thalidomide maintenance is important for discussion's sake, at least in areas with meager resources, or if the patient cannot afford very expensive drugs, then at least we have some data to back up in terms of offering them thalidomide maintenance. These are 7 different studies, and you can see at least 2 of them had improvement in terms of overall survival, but almost all of them had some improvement in progression-free survival. And this is the Canadian study in which they had shown that progression-free survival in terms of combination of thalidomide prednisone did better compared to observation alone. It did not translate into improvement in overall survival. And in a meta-analysis, however, they showed that all the factors, or when combination of all these studies, they showed favorable for thalidomide maintenance, and it was also in favor for overall survival. What about post-transplant bortezomib therapy? So there are at least 3 separate studies that have looked at bortezomib maintenance, and these are weekly maintenance or every 2 weeks. And what you can see is that, again, there is improvement in median progression-free survival. In all 3 studies, there is only 1 study that showed some improvement in terms of overall survival. But really, the maximum data that we have is in terms of lenalidomide. There are maximum number of studies being done and reported with lenalidomide maintenance. There are 2 independent randomized studies that are out there, and this is the French group, et al., where they showed that with the lenalidomide maintenance, there was improvement in terms of progression-free survival, and in CALGB, which was done in the United States, where it showed not only improvement in progression-free survival, but also improvement in overall survival. This is the data that is representing the improvement in the progression-free survival. You can see that the curves are really separating, and there is a real effect, but in terms of overall survival, the difference was positive only in the CALGB study. Not to mention that it also comes with significant toxicities. The hematologic toxicities were expected, infections were expected because of the cytopenias. However, which was not so expected was the secondary malignancies, and in fact, based upon the incidence of secondary malignancies, at least the IFM group had held their study prematurely and basically had caution in terms of, and it created a lot of issues. This is a more recent study in which they had looked upon patients getting lenalidomide-based induction followed by transplant followed by len maintenance versus no maintenance. The bottom line was that if you just compare patients with high-dose melphalan followed by len maintenance and high-dose melphalan with no maintenance in yellow and blue line, you can see that there was significant improvement in terms of progression-free survival, and there was hint towards improvement of overall survival as well. So in terms of a meta-analysis, looking at all these 3 randomized studies, the results were basically all in favor for lenalidomide maintenance. The 7-year overall survival was 62% in favor of lenalidomide compared to 50% in control arm. And basically what they had shown was that based upon this data, the risk versus benefit is more in favor of the maintenance versus the issue of secondary malignancies. So now comes to the last part of the talk in terms of consolidation. What is the optimal consolidation? What is the need for consolidation? So I'll take you back to the era of tandem transplants and total therapy, when we used to upfront offer our patients 2 transplants at the time of initial evaluation for autologous stem cell transplant, and it comes from data presented from different hospitals and different institutions, where you can clearly see that the progression-free survival was in favor of the tandem transplants, and the overall survival was benefited only in 1 study. But truly speaking, at least in our practice, we had adopted it routinely to offer tandem transplants, because the second transplant offered as a consolidation to the first transplant. And this is the total therapy data that comes from Dr. Bartlogi's institution, and again showed improvement in terms of the progression-free survival at least. However, in the modern perspective, we are trying to do more with less in terms of offering less toxicity to our patients and maximizing their responses and maximizing their quality of life. Therefore, immunomodulatory agents being incorporated as conceptually in the post-transplant consolidation is gaining more strength. And this is the data in terms of the lenalidomide based consolidation, and you can see in the induction it was VAD or VD based induction, and before consolidation the VGPR was close to 60%. After consolidation it improved to 69%, and the progression-free survival was significant. However, no improvement in overall survival. In terms of bortezomib based consolidation therapy, again you will see that the near CR improved from 20% to 45%, the VGPR improved from 40 to 71%. Again, improvement in progression-free survival, but not much effect in terms of overall survival. There is also data of combination of bortezomib thalidomide based consolidation therapy. I think Dr. Arlowski had mentioned it briefly, but of note is the Liliu study, in which they had used VTD in terms of induction and consolidation, and they showed that the CR rates had gone from 33 to 52% after the consolidation in this case. And now there are combinations of bortezomib and lenalidomide together, which is very, very promising. I do want to briefly mention about minimal residual disease monitoring as well. And what has happened is that with the consolidation therapy, the MRD rates have also gone up significantly. And here you can see very clearly in the VTD study, with the VTD consolidation, the before consolidation MRD was only 3%, and after that it went up to 18%, and it's consistent amongst other studies as well. I do want to summarize the stamina data that was presented late last year, and this is very humbling because all the phase 2 the smaller studies can give us good data, but myeloma is a disease of long follow-up, as well as it really puts our knowledge to test and our experience to be evaluated. So here is a study in which all patients underwent autologous stem cell transplant, and then they were randomized into 3 parts. Either they were, after the transplant, they went on to len maintenance, or they underwent consolidation with VRD, or they got a second transplant, and all of them had lenalidomide maintenance. Bottom line was that there was no difference. Because everybody went on to lenalidomide maintenance, the consolidation, either in form of the VRD or a second transplant, did not lead to any major difference in terms of outcome of either progression-free survival or overall survival. But as in any other study, the follow-up is still very short, especially for myeloma. You need at least 5 to 6 years of follow-up to make a reasonable decision. And in this case, the number of second malignancies were not really different. It was not an issue in this case. And the investigator conclusions were that based upon a largest randomization study to evaluate for post-transplant manipulation, at least based upon this data, it shows that when lenalidomide maintenance is provided, then the VRD consolidation didn't really lead to much of a benefit. So what about novel therapies, and this was the data looked upon IRD. So I'll just walk you through. All patients got Ixazomib, Revlimid, Dexamethasone induction, followed by autologous stem cell transplant, and then at 2 months they got IRD consolidation for 2 cycles, and then subsequently late consolidation of 6 cycles, and they all went to Ixazomib maintenance therapy. And bottom line was that with every single step, the depth of the response actually continued to improve. So after the 3 cycles of IRD, the overall response rate was 81, CR rate was 12%. Following autologous transplant, the CR rate went to 38%. Following the consolidation of the early 2 cycles and 6 additional cycles, the CR rate went to 44%. So definitely it tells us something about the sequencing of the therapy and offering them novel agents. This is the study that is being now presented and is undergoing accrual, in which we have induction therapy followed by autologous transplant and IRD consolidation, and then randomized to Ixazomib maintenance versus lenalidomide maintenance. So I think that in this day and age, we are very fortunate, our patients are very fortunate to have the chance to be exposed to such novel agents, and at least based upon these data, we feel that autologous stem cell transplant, because of the lower mortality, because of better accessibility, because we are able to support our patients better, will become one of the standard of care in terms of the many therapies that our patients will have. And definitely post-transplant manipulation is also here to stay. So with that, I thank the chair and organizers. Thank you very much.
Thank you. Any questions from the audience? Let me start with a question.
Nonetheless, there are some who will not be eligible, and what should we do for those will be answered by Professor Li from the First Affiliated Hospital of Sun Yat-sen University, so please give her your best attention.
Thank you for your introduction, President. Also, I want to thank the organizer of BTG for inviting me here. Good morning, ladies and gentlemen. Today, I'm honored to discuss with you about the first-line therapy for patients with transplant-ineligible, newly diagnosed multiple myeloma. It's well known that multiple myeloma is a malignancy of elderly. According to the SEER report, myeloma is most often diagnosed among people aged 16.5 to 17.5 years old. The median age of myeloma patients at diagnosis is nearly 17 years old. As known on this figure, with the introduction of novel drugs, the 5 years overall survival between 2006 to 2010 was improved compared to that between 2001 to 2005. For patients younger or equal to 16.5 years old and the patients older than 16.5 years old. However, the improvement in patients older than 16.5 years old was far less remarkably than that in younger patients. With the CISS stage and the FISH results, the patients older than 16.5 years old had a poor survival than the younger patients. You can see the patients older than 16.5 years old with ISS stage 3 and the poor FISH had the worst survival. This result indicated that age is highly associated with the survival in multiple myeloma patients. Age older than 16.5 years old is a poor prognosis factor. Similar performance data has impact on the survival. As shown on this figure, the frail patients had a significantly lower 1-year-old survival rate than the fit patients had. What's more, the multivariate analysis indicated that frailty might more remarkably increase the death risk than ISS stage and the poor FISH do, with the highest hazard ratio of 3.1. Hence, frail data and older than led to ineligible for transplant in some patients with a newly diagnosed myeloma. To achieve the best outcome in these patients, then how should we choose the optimal drugs and the regimens as a frontline therapy for these transplant-ineligible patients? Today, we will focus on the initial therapy. Drugs available as the first-line therapy are abundant. They could be classified into alkylator, such as methylene, cyclophosphamide, steroids such as dexamethasone, prednisone, anthracyclines such as doxing, liposomal doxing, immunes such as thalidomide, lenalidomide, and pomalidomide, and proteasome inhibitors such as Bortezomib and Carfilzomib. In the age of novel agents, the corresponding common regimens for transplant-ineligible patients includes those containing immunes such as CTD, MPD, RD, those containing PIs such as VD, MPV, PAD, and those containing both immunes and PIs such as VRD and VTD. In the following several slides, we will briefly review these regimens. For CTD regimen, 3 clinical studies had shown that its overall response rate was greater than 16%, with PFS of 13 to 25.9 months and the OS of about 3 years. For MPT regimen, the overall response rate ranged from 15.8% to 17.6%. The CR rate reached as high as 23%. What's more, 6 clinical trials showed that the PFS was improved in 5 trials and the OS was improved in 3 trials with MPT regimen. For PAD regimen, 1 clinical trial showed that VGPR plus CR rate after induction therapy was 15.8%, and the 2-year overall survival rate reached 18%. Also, the safety is good for PAD regimen in elderly patients. Common grade 3 and 4 ACE during the induction, including thrombocytopenia, neutropenia, peripheral neuropathy, and pneumonia. In the famous VESTA trial, 6-week cycles of MP plus Bortezomib regimen was compared to MP regimen. The primary endpoint was TTP, and the secondary endpoints including the risk rate, TTR, DOR, OS. The result is amazing. By the EBNT criteria, the CR rate of MPV regimen was as high as 13% compared to only 4% of CR rate with the MP regimen. As shown on this table, the time to first response, time to CR, and the duration of response were all superior with VMP to that with MP regimen. As for the long-term outcome, the VMP group had a significantly longer PFS than the MP group. The median PFS was 21.7 and 15.2 months in the VMP and the MP group, respectively. With the median follow-up of 16.1 months, the median OS benefit with VMP was 13.3 months, and the death risk was reduced by 31%. For the adverse events, the most obvious ones for the VMP group were peripheral neuropathy, neuralgia, and diarrhea. Another famous trial is the first trial. In this trial, patients were randomized into the continuous RD 18 cycles, and the MPT 12 cycles. The randomization was stratified by the age, countries and the ISS stage. The median PFS with continuous RD, RD18, and MPT were 26, 21, and 21.1 months respectively. The continuous RD group also have significantly higher 4-year PFS rate of 33% than the RD18 group and the MPT group did. With the median follow-up 14.4 months, the 4-year OS rate was 16% with RD continuous, which was similar to that with the RD18 of 15.7%, however, superior to that with MPT of 15.1%. Most of adverse events were comparable between the three groups without significant differences. However, the RD continuous and the RD18 groups had a lower incidence of peripheral neuropathy than the MPT group did. In the surgery, VRD regimen combining PI and the IMIA was compared to RD regimen. The results showed that both PFS and the OS were superior with the VRD to that with RD regimen. With the median follow-up over 6 years, the median OS has not been reached yet with the VRD regimen, whereas 16 months with the RD regimen. The OS was improved by an average of 1 year with VRD. VRD regimen is expensive, and the prominent efficacy is expected for this regimen combining two categories of nerve drugs. As shown in the IFN trial and the evolution trial, the VRD regimen can overcome the poor prognosis of high-risk cytogenetics. Above, we have briefly reviewed the several common first-line regimens for the MM patients ineligible for transplant. In summary, just as recommended by EMN, the patients not eligible for transplant could choose CTD, MPD, VMP-RD regimens. Comparison of PFS and the OS among these different regimens show that regimens containing lenalidomide or bortezomib, such as MPV, MPRR, and RD, had similar outcomes, but regimens containing only thalidomide, such as CTD, MPD, and TD, had relatively poor outcomes. Similar to patients younger than 65 years old, patients with transplant ineligible newly diagnosed multiple myeloma should also receive stratified therapy. Then, how to choose the optimal regimens for the majority standard risk patients with normal renal function, for patients with renal insufficiency, for patients with high-risk FISH, and for patients with poor economic status. A meta-analysis had compared the relative efficacy with RD continuous to that with MPV, MPT, and MP regimens for patients with transplant ineligible newly diagnosed myeloma. This analysis screened 1993 articles, and the last 88 articles were included in the review representing 52 unique trials. A network analysis was done to compare RD continuous, MP, VMP, and MPT regimens. As shown on this plot, the results show that compared to the other three regimens, RD continuous decreased the relapse risk by 31 to 62%, with the hazard ratio of 0.38 to 0.69. Also, RD continuous regimen decreased the death risk by 25 to 54%, with the hazard ratio of 0.46 to 0.75. According to this meta-analysis, we recommend RD continues as the therapy of choice for majority patients with standard risk. How about the patients with renal insufficiency? The VISTA trial showed that no matter the CCR was less than 13 milliliter per minute or greater than 15 milliliter per minute or betray, the 1 year, 2 year, 3 year OS rate were similar. With the median follow-up of 36.7 months, the OS were of no significant differences in patients with CCR equals to or greater than 60 milliliter per minute, and those with CCR less than 16 milliliter per minute. The data from China also indicated that patients with renal insufficiency could benefit from regimens containing Bortezomib. Hence, for patients with renal insufficiency, the regimens containing Bortezomib could overcome the adverse prognosis of renal insufficiency. The next issue we will discuss about is the high-risk cytogenetics. Patients with high-risk cytogenetics always have poor prognosis. Across the clinical trials, focus on the patients with transplant-ineligible myeloma patients, we can see that about 10.7 to 18.8% of the elderly patients had a high-risk cytogenetics abnormality. Then was the impact of cytogenetics on the outcome of patients with transplant-ineligible MDMA in the first trial? Could the poor prognosis of high-risk cytogenetics be overcome by continuous RD? In the first trial, among 762 patients with a FISH result, 19% of patients had a high-risk cytogenetics, including translocation 414, translocation 1416, and the 17p deletion. The results show that, similar to RD and the MPT, RD continuous could not overcome the poor prognosis of high-risk cytogenetics on the PFS. The 3-year PFS rate was 3%, 10%, and 3% with the RD continuous, RD18, and the MPT regimen, respectively, without significant differences among them. Later, the OS was improved with the RD continuous compared to the RD18 or MPT for patients with high-risk cytogenetics. However, the VISTA trial showed that the median overall survival were 14 months and 41 months, respectively, in patients with high risk and those with standard risk cytogenetics, with no significant difference between these two groups. Therefore, regimen containing Bortezomib might be more optimal for patients with higher risk cytogenetics. The last issue that needs to be considered is the cost. As shown on this figure, 18 cycles of RVD RD cost about 517,000 RMB and 417,000 RMB respectively, while 8 cycles of CTD or MPD only cost about 5,000 RMB. Hence, CTD and MPD might be a good choice for patients with poor economic status. In conclusions, regimens containing immunes such as CTD, MPD, RD, regimens containing PRS such as VD, MPV, PAD, VCD, and the regimens containing IMiDs and the PIs, such as VRD, VTD, could all be chosen as the first-line therapy for patients with transplant-ineligible, newly diagnosed myeloma. For patients with severe renal impairment, we could choose Bortezomib, Thalidomide, Pomalidomide, cytophosphamide, or Dexamethasone. For patients with high-risk cytogenetics, proteasome inhibitors improve the outcome in patients with poor prognosis of high-risk genetics. For patients with poor economics, consider CTD and PD. This is the end of my presentation. Thank you for your attention.